Hello, everyone. Welcome to another webinar from the Steps Forward Innovation Academy. Today's topic is human factors in healthcare, engineering better well-being for physicians. Over the next 45 minutes, we will discuss how healthcare can be designed to support both patient safety and team well-being. Please note, this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. Now let's just take a moment to go over your experience today as an attendee. If you are joining us on Zoom, you will see a dark menu bar either at the bottom or the top of your window. There you can access a selection of resources related to this webinar, including today's slides. There is a link to stepsforward.org where you can find all of our past toolkits, podcasts, and webinars. If you don't see these options, select the three-dot More button to access the resources and Q&A. If you're joining us on YouTube or LinkedIn, welcome. You can follow the link in the description to join us here on Zoom, access the resources, and ask questions for our speakers to answer. After the webinar concludes today, you will be able to claim 0.75 continuing medical education credit hours. You can follow the link in the Resources tab to the AMA EdHub and claim the credit there. We'll remind you of all of this at the end, but for now, I would like to introduce you to today's speakers. Joining us today is Dr. Elizabeth Harry, the Chief Wellbeing Officer at Michigan Medicine, and Dr. Heather Farley, Vice President of Professional Satisfaction here at the American Medical Association. Dr. Farley, I will turn it over to you.
Thank you, Alec. Well, welcome everyone, and Dr. Harry, thank you for joining us. Today we'll be exploring the science of human factors, how the design of our systems, our workflows, and our technology can either support or sabotage our ability to think clearly, work safely, and find meaning in what we do every day. Our specific learning objectives are first to describe practical strategies for reducing cognitive load and improving workflow efficiency in healthcare environments. And second, to discuss how user-centered technology and thoughtful system design can ease burnout, boost team satisfaction, and create safer, more sustainable care environments. And our agenda together today, we'll kick off with a primer on cognitive load and attention and discuss why this concept is so important to physician and care team well-being. Next, we'll share best practices on how to measure cognitive load and cover some case examples of how applying human factors engineering principles lead to real improvements in cognitive load and well-being. And finally, we'll be sure to leave some time for Q&A at the end. So, Dr. Harry, I know you've spent years studying cognitive load in clinical environments. Can you kick us off by helping us understand what cognitive load is and how it comes into play in our clinical environment?
Yeah, thank you so much, Heather. I really appreciate it. I'm so excited to be here and so excited to join you all. And, before we started, we kind of wanted to poll the audience and just think about when you hear the term cognitive load and you think about your workday in the past 2 weeks or so, what do you think are the biggest drivers in your workplace? And if you can throw some things in the chat and we'll take a look at that over time, but I just want to throw that question out as we start so we can move forward and we'll keep an eye on the chat. So that we're all coming from the same place and sort of understand what we're talking about, it's really important to understand that all humans have a limited short-term working memory. And short-term working memory is your ability to understand something from the environment and learn it, or your ability to act on something from your knowledge and then act on it and bring it forward into your words, behaviors, etc. So it is a finite resource, the short-term working memory. And that is a really important concept because we don't treat it like a finite resource. And this finite resource shrinks when we are emotionally or physiologically stressed. So that's called attention tunneling, and our ability to focus on the number of things sort of decreases in that situation. And we can hold about 5 to 9 items at a time. Interesting fact, this is why phone numbers were originally 7 digits long, because it's an easy amount of numbers to remember. There are 3 things that impact how much of our working memory we're using at any given time. And the first is intrinsic cognitive load. This is the task that you're doing. This is the number of elements that interact to do the task, and it's intrinsic, as the name suggests, to the task itself. So it's not modifiable. So that's sort of the thing that we're doing. and we'll put that to the side because we can't modify it. Then germane cognitive load is how much of your working memory you're learning, either about the task or about, a mental model related to the content that you're working on, or learning about your patient. But this is a great part of our working memory because this develops new skills, new cognitive capacities, new physical capacities. So we want to have space for this. This is really important. And then extraneous cognitive load has nothing to do with the task itself or us learning about the task or other pieces related to the task. It's all about how we designed the task and how the information is presented to us. And it can be low if we've designed things well, or it can be very high if we've designed things poorly. Can move forward to the next slide. And this is where the money is. So thinking about extraneous cognitive load when we think about our systems is really important because, as we talked about, you can't change the complexity of the task itself. That's sort of fixed. And we want to free up space to be learning. That's not a space we want to be decreasing our cognitive load from. So where we want to be intervening, so we're not using all that working memory, is in this extraneous cognitive load space. And it's decreased with three things. So standardization. So I want you to think about, why do you put your keys in the same place every day? Why do we do our physical exam in the same order? Why do we try to standardize checklists and routines? And we'll talk a little bit more about that. Consolidating information, bringing everything you need together before working on something. So instead of having to get a patient's vital signs from over here and their labs from over here, and maybe a consultant note or recommendation from over here, you have everything you need on, say, one diabetes screen that shows you their inpatient glycemic control, their outpatient glycemic control, their medications, their refill history, maybe other pertinent labs, all in one area, so that it consolidates everything you need so you can make your decision from that space. Again, the idea here is that it's reducing split attention or interruptions, and we'll talk more about that. And then the third is reducing redundancy. And that is the number of times that we see the same information coming back at us. And that really drives cognitive load. So think about the number of times you're either given information, given a document about a patient, told the same information. All of that is driving cognitive load higher.
Dr. Harry, the three strategies that you just described, I know come from human factors engineering principles, right? And what I love about human factors engineering is that it's all about fitting the system to the human rather than forcing the human to adapt to the system, right? And that I remember the first time that you shared some of these concepts with me, and that delineation of the different types of cognitive load and how important it is for us to figure out where that extraneous cognitive load is coming from, because that's oftentimes what gets us over into that zone of where the demands are exceeding our available resources. And we know that when we're stuck in that zone and it's sustained over time, that's what leads to one of the factors that can lead to increasing burnout. So fascinating, and knowing now how our brains work and how what some of our limitations are as humans, I'd love for us to dive a little deeper into our humanness and discuss some of the important aspects of human attention that come into play here. And I think that's what you're about to share with us next.
Yeah, absolutely. And it's a great point. So cognitive load theory comes out of educational psychology originally, which helps us think about how do we learn. And it has really been adapted really well by human factors engineers, organizational psychologists, thinking about, well, how do we put people in the workplace in a way that they can thrive, and thinking about how we design systems, to your point, Heather, to build systems around our humanness, not try to sort of squish our humanness around the systems. And so in order to do that, we have to understand how we can attend, because our attention is our ability to take that working memory and to focus it in a particular place and to use it well. And so there's multiple ways that we can attend. So the first is sustained attention. That's what all of you are doing now who are listening to this, I hope. Maybe some of you are doing alternating attention, and we'll talk about that in a minute. But sustained attention is when you pick something to pay attention to for a long period of time. And we know that the ability to do this is sort of decreasing over time, because the way we're designing our societies, with the way we're designing our systems, we don't sit and attend for as long as we used to. And so I want you just to notice in yourself the last time you had a prolonged period of sustained attention, and what the draws are to like pull your attention away. There's selective attention. This is when you're in a busy environment and you're able to sort of take your attentional resources and put them in one place and not something else, and sort of intentionally sort of not pay attention to that. And then there's alternating attention. And this is what you do when you think you're multitasking, but we're not computer processors, so we don't actually multitask. We task switch. There are very few people who can actually multitask. But they do what's called task switching, and they move from one focus to another and back again and back again. And every time you switch, you lose 90 seconds of data, and it's called an attentional blink. And at best, it's an inefficient way to work because you're losing 90 seconds of data every time you switch. And at worst, it's actually dangerous because you can actually lose data during that period of time that could be crucial, or information from the patient that would be really important to get. And then there's the worst kind, which is continuous partial attention. You know, you've done this when you get home at the end of the day, someone you love says, "What would you like to eat for dinner?" And you say, "I couldn't possibly make another decision." And the reason for this is that you continually depleted your working memory throughout the day, either by doing this continuous partial attention, this sort of alternating attention, or just even with sustained attention for a long period of time. And we'll touch on that a little bit later too, without ever giving yourself a cognitive break to kind of restore your working memory. And then you've just sort of depleted it all. We can go to the next slide. Thank you. So to give us a sense of how we attend, I took this screenshot out of a familiar video, I think, to most, and I didn't want to replay it because I think most people have seen it. But for those who haven't, this is a selective attention test. And what the study does is they have participants in white shirts and participants in black throwing a basketball. And your job is to count how many times the participants in white throw a basketball. And so you're so focused on the participants in white and how often they're throwing a basketball that most people actually don't notice this, which is amazing. If you look at the still shot, the gorilla is huge, but most people actually don't notice the gorilla walking through because you're paying attention to the people in white. We can go to the next slide. So I love this study. I just think it's really fun. So they took that principle and they adapted it to healthcare to understand how we have selective attention, or attentional blindness, if you will. And so if you look on the top left to begin with, you can see that they took the figure of a little gorilla and they actually put it in a pulmonary CT scan. And they put it across 5 different frames at different transparencies. And if you look at the top right picture of the CT, in the very sort of, it would be sort of the left upper area of the patient, you can see the little gorilla. And if you look at the bottom right screen here, you can see that there's a purple dot right over where that gorilla is. This is where people's eyes were. So the radiologists that were reading these films looked at the gorilla. And so when they had a bunch of radiologists look at this film, 83%, 20 out of 24 who looked at it, didn't report the gorilla. They didn't see the gorilla at all. And 12 of those 20 missers looked directly at it. So you can see from this eye tracking software that they looked at where the gorilla is, but they didn't process it. Now, you could say this is not what we're trained to see, and so it's an unfair study, and there's a lot of criticism that you could put towards this study. But I think the important concept here is that when you're looking for something, whether it's people in white throwing a basketball or pulmonary nodules and what you're used to looking at, you're not going to see something else, even if it's sort of outrageous and strange and doesn't belong there and should, in theory, draw your attention.
For those who have never seen that video or heard that study, it truly is a humbling example of the limitations of our brain and our attention, which I was personally experiencing as I was checking on our chat. I think we're working on getting that back up, but I think in the meantime, folks were using the Q&A. But so Liz, let's move into some data from the healthcare environment. What do we know about some of those sources of extraneous cognitive load that threaten our precious attentional resources? You and I have talked in the past about interruptions being a big source. Can you share a little bit more about what the data tells us here?
Yeah, interruptions are huge, and we're one of the only sort of high risk industries that hasn't really honed in on this in a really big way, even though we have a lot of data to support that we know we're interrupting each other and we know that it has harm. And yet we aren't really designing around it quite yet, whereas in other industries, there are protections around interruptions. So there was a study done by Westbrook and colleagues that showed every interruption during a medication administration was linked to roughly a 12% increase in procedural failure and clinical errors. They've looked at ED prescribers as well, and either interruptions or that multitasking that we talked about, as well as poor sleep, because it decreases that working memory. It also decreases your ability to have time on task, increased our error rates. I really love this study that was done in the ED, looking at 180-minute observation of ED physicians. And Heather, this may touch close to home for you, but folks saw on average about 12 patients, plus or minus 4. They completed 67 tasks, plus or minus 15. They were interrupted 30 times, broke their own task 20 times, and interruptions increased with a higher patient load, and breaks in task increased with a higher patient load as well. PCPs, so hits home for me because I'm a PCP, averaged about 79 attention switches per day associated with inbox work. And remember, every time we're doing that attention switch, we're losing 90 seconds of data. There have been studies that have shown that poor EHR usability is linked to a patient safety hazard. And the Joint Commission in 2013 put out their Sentinel event alert, actually called alarm fatigue as a known risk for driving desensitization and missing critical alerts. And I don't know what your personal experience is, but mine is that it seems like the number of alerts just increase. So despite the fact that we know this, the way that we're designing systems doesn't seem to reflect this knowledge.
Exactly. Yeah. And that data around interruptions is pretty staggering. and certainly it was a little too close to home for me, and I'm sure for many who are on this call.
Yeah, absolutely. And then we talked a little bit about fatigue and time on task earlier and the impact that has. So there's a couple studies that have been done, particularly looking at our residents and looking at residents working more than 24-hour shifts. And they made substantially more serious medical errors compared to those with shorter shifts. And a lot of this drove some of our duty hour regulations. And the mechanism is this drop in vigilance or vigilant decrement and attentional lapse with prolonged wakefulness. So we know that the longer that you're awake, the harder it is to pay attention. And we also, there's classic vigilance research that really tells us that our performance drops with time on task. So the longer time we're trying to stay on task, the more our performance drops. And then sustained attention becomes more effortful. And we know that, right? Like when we start getting tired, we sort of pull ourselves away from the task a little bit. And instead of just taking a true cognitive break, oftentimes we do things that deplete our cognitive resources in a different way, like scrolling or something like that. So this is where micro breaks, task variation, again, this is not task variation by self-interruption, but this is starting completing a task, then doing a different but unrelated task can show benefits.
And I love the idea of micro breaks. And this is something that I talked about frequently, and my team talked about in my previous role as a CWO at MUSC, and the importance of, especially as physicians, we don't get to take a half-hour break or even an hour break for a meal or anything like that oftentimes. And so, our brains and our bodies are not wired to have that peak physical and mental attention for such a sustained period of time. So, and at the same time, we're so driven and we're so task oriented. Like, I've got to get these 50 things done, and you just want to put your head down and motor through it. But we need to understand that it's not a sign of weakness. This is just how we're wired. We absolutely need these micro breaks, not only for our own well-being, but also for us to be able to perform maximally.
Yeah.
I love that idea.
Well, and what I love about what you're saying, Heather, is just like really acknowledging the humanness and that it's to amplify our performance, right? So it is so we can do better by our patients and for ourselves and everybody else that we engage with. Absolutely.
And I think you've got some more. Yep, I thought you had some more data on overload and burnout. Great.
Yeah. So, a lot of times I feel like I give some of these talks, and people are like, why in a well-being space is this person talking about, workload and interruptions, and what is the relationship here? And so there are some studies that have looked into this. So Lisa Rodenstein and some of her colleagues showed that work overload was associated with anywhere between a 2.5 times and even up to close to a 3 times greater risk of burnout, depending on people's role type. There were several of us that were involved in a study looking at provider task load, which is sort of a derivative of the NASA task load index, and we'll talk a little bit about that, and showed that for every 10% increase in the task load index, there was a corresponding 33% increase in the odds of reporting burnout. And there were particular fields that had higher task load. There have been studies and my purpose in including some of these is to make it really clear that this isn't just physicians, that there are studies of acute care nurses that show that high workload demands are associated with burnout and lower job demand. There's a great study in the American College of Surgeons looking at hours worked and increased medical errors, and then nursing education assessed mid-level academic nurses, and they found that they had those that reported higher workload, poor work-life balance, and longer work hours had heightened burnout risk. So there's a relationship. Now, we don't obviously know which direction the relationship goes, and none of these are sort of prospective randomized controlled trials, but we know there's a relationship between being overloaded, between having these longer work hours, and burnout.
So you've covered some great background data here. Can you kind of sum all of this up in a sense, and why does all of this data really matter?
Yeah, I mean, I think that the big picture is that, this work then taxes our working memory and our attention, that the way we've designed the systems, we have incredibly fragmented workflows. We have things like our in-basket volume. We have the way that we even communicate between team members. People are talking a lot about chats versus pages, interruptions, and the multiple modalities with which we can interrupt now. And all of this, the way we choose to design our systems, our EHR usability, our team workflow, all of this coalesces onto a person, a human that has sort of limited cognitive and physical capabilities. And it increases the risk of error, it increases the risk of burnout, and it makes it harder for us to engage meaningfully in the reason that we came to do this field, which is to connect with our patients, to be able to deliver excellent care, to connect with our teams in a really high functioning way. And so I think understanding this, understanding the risk that this poses to our physicians, to our care teams, to our patients, really helps us rethink about why we might want to prioritize some of this system redesign from not only the end of patient safety, but also, our care team well-being.
So well said. I mean, you shared some pretty powerful data showing that work overload and cognitive load specifically is tied to burnout risk, and not just for our physicians, but across many care team member roles. You've made such a compelling case that addressing these cognitive load challenges that have existed for a while, but seem to be amplifying. And we've, I think are kind of late to the game here to recognize how important this is. But when we do address those challenges, we can create a more efficient and supportive work environment, which ultimately leads to better patient care and improved care team experience and well-being.
Yeah.
So, where do we go from here? How do we begin to identify some of those sources, to apply some of those design principles from human factors engineering? And specifically, how do we know if we're making a difference? How do we measure our progress?
Yeah, it's a great question. And so I think, part of it is we all know anecdotal stories. And I think we're seeing some in the chat, right, where people can describe parts of their workday that feel very overloading. And what we need to do then is be able to really collect the data and understand, where are people being overloaded? What is the implication? How much time are they spending in the EHR? And really getting sort of hard data to support this. So we have perceptual measures, but then we want to pair that with like our provider task load that we talked about, which is a derivative of the NASA task load index, which is free. There's an app, so any of you can download it on your Apple device or your Android device, and you can go in and measure a process in your work environment and see what the task load is. And then we want to pair that with operational metrics. So you could look in your EHR, and many of them now offer the ability to look at how long are providers spending in the chart after hours, how long are they spending in the EHR, looking at in-basket messages versus putting in orders versus reviewing notes or data, and really trying to get granular and understanding how these system designs are impacting our providers. Now, we know that, do you want to take that data and go to the provider and say, hey, your work outside of work is high, therefore you might be burnt out? Probably not. But do you want to look at the system level and say, well, there's this clinic where everyone at the clinic has really high work outside of work. Is that a clinic we want to go target? The answer may be probably yes. And so then you take those results and those actionable data that we talked about gathering, and then you prioritize work redesign in those locations.
I think that's a really practical, solutions-based framework. So maybe let's shift gears and kind of bring everything we've talked about so far to life for the audience. So let's talk about maybe some specific use cases, some examples of how we're identifying sources of extraneous cognitive load, applying those human factors principles, and then seeing real measurable results.
Yeah, and I think so there's some stuff that's really exciting and it's like new technology, and then there's some stuff that's very low tech, right? That's been around for a while that is actually very robust. So checklists are a great example of a low tech. It's been around for a while, but it creates standardization. It reduces that split attention, and so this is a study I like because it was a systematic search across many platforms to look at the impact of using checklists. And it looked at 69 unique checklists, and there were different kinds. There were rounding ones, delirium screening, transfer handovers, collapse prevention, airway management. And they looked at sort of the different formats, whether they were EHR embedded or not. They looked at the adherence, and they found that 72 of these studies had significant findings, and that 90% of them were positive in terms of either process of care outcomes, such as decreasing ICU length of stay, decreasing mechanical ventilation days, decreasing CLABSIs, improved information transfer. So I think it's really important whenever we're starting to think about how to do some of this, that there's like low-hanging fruit that may not be the most glamorous, but that is very effective. We can go to the next slide. Yep, so this is another example. This gets a little more high-tech, but this is looking at portal messages and portal message burden in primary care. This is a colleague of mine actually here from University of Michigan, and what they noted was a surge in patient portal messages during COVID, and so they wanted to do this quality improvement process. They put a best practice statements document together and developed a routing guide. It created dedicated time for PCPs for message management, and they looked at the messages per physician, the percent of message encounters that involved physicians, and the percent that had a carbon copy message, right? And of course, that redundancy piece really drives that cognitive load. And what they found is just by this like simple intervention of having sort of a routing guide and a best practice document of like, think about where you're sending this, and then some dedicated time to actually manage the in-basket, they saw a 16% reduction in messages per physician, a 65% reduction in carbon copy messages, and stable physician involvement rate. So I think, again, like these aren't the most complicated interventions, but they have impact in our cognitive load and the amount of data that we're managing.
Yeah, and this portal message burden is such a huge source of distress for folks. So, and to your point, there's some really complex ways that we can address this, and some really simple ways. So it really runs the gamut. So I appreciate you highlighting some of the sort of easier ways that we can approach decreasing one of these significant sources of extraneous cognitive load.
Well, and what I love about this one, is shout out to Michael Privatera, who I know who's on, is, he often talks about the socio-technical model, right? And we have this technology, but we often don't think about the social aspect of how we use the technology and how we're teaching our teams to use the technology together. And so really what this study did nicely is that social aspect of that socio-technical piece. We can move to the next slide. So this gets a little more high tech, right? Where we're talking about evaluation of ambient documentation, or AI generated notes. These were two early studies looking at nuanced DAG. So this would be Microsoft's product, and finding that, and for those that may not be familiar, so this is where you have a product as part of your electronic health record. It sits usually on your phone, and you're able to set it down between you and the patient. It listens to the visit and then generates a note that then you can edit. And what they found was boosted clinician engagement. In this particular study, it failed to reduce after hours EHR time. So one might postulate, like, is that because they're spending more time editing the note than just drafting the note? They did look at provider engagement surveys, which improved. There were no safety events related to implementing this, but the after hours time actually increased in this particular study. That isn't seen across the board in all the studies. There was another follow-up study showed that a 7-week pilot of this tool cut note and after hours time by about 20 to 30% and improved perceived efficiency. So again, this kind of contradicts the last study a little bit in this after hours time. They did see a decrease in time and notes per appointment, work after work, and an increase in same-day note closure. So I think the point here is that there are more sophisticated tools coming out, many of which are embedded in the EHR. Now we're starting to see chart summarization tools coming out that really reduces our extraneous cognitive load, the ability to pull that signal from the noise and really tell you what's meaningful. But of course, these are new. There's risk for error, there's risk for hallucination. And so we have to be very vigilant as we're adopting these tools.
This is certainly a hot topic, and for anyone who was at ACPH a few weeks ago, there were a lot of great studies and presentations on ambient documentation. And what I like about this example is it brings together this thought of reducing some of those sources of extraneous cognitive load, but enables us to focus on the good cognitive load, right? Our medical decision making and our human connection with the patient. And I think the risk here is that what do we do with the time that we're recapturing there, with the attention that we're recapturing there? Potentially, are we just repurposing that to shove an extra patient in there and generate more RVUs? So I think this is the promise and the risk of this technology too. Is we've got to be really careful about what we're measuring in terms of what success looks like here, and how we are using that potential saved time and energy, and have that go towards things that are the good part of our cognitive load, as well as what brings us joy in our work of that human connection, and maybe some opportunities for some micro breaks so we can reset our attention, right?
Yeah, absolutely.
So, thank you, Liz. I think people always appreciate when we share very specific examples to help bring the theory to life and demonstrate that, yes, we can do this effectively in the real world. And you've covered so much ground. Hopefully we all now have a better understanding of the concept of what cognitive load is, how our attention works, and appreciate better why this field of work is so important to physician and care team well-being. We've shared some best practices on how to measure cognitive load and covered those specific examples of how applying human factors engineering principles can lead to real improvements in cognitive load and well-being. And I think we both hope that everyone who is listening today is interested in learning more and taking the next step in their own organization. So what are some options that you might recommend for people who want to take the next step?
Yeah, so I think, you can go anywhere from starting really local, even in your own clinic. And like I said, the task load index is free. You can download it as an app there's a 4-item version, but you could do the full 6-item version. And measure task load on a particular process, and then try to redesign it, and then measure task load again and see if you're able to reduce the task load. So this is something you can do very locally. Looking at some of this in-basket data. So a lot of organizations don't spend as much time looking at some of this data that we have available to us on how are people spending time in the in-basket? How many times is a physician or a care team member touching a message? Is it going round and round and there's redundancy there? This auto CC concept, where are we creating redundancy and cognitive load for others? And then a much more sophisticated version of this is looking at audit log data, which is just keeping track of every keystroke and every mouse stroke in the EHR and really understanding how people are spending their time. There can also be a multi-site learning. So I know a lot of places are trying to solve this together. And so many places are trying to come together and say, well, let's look at this data together. Let's do an intervention like this, and let's do a multi-site study that we can try to test and scale effective redesigns and looking at some of this. And then I love all the playbooks that you guys have, Heather, which I think are so helpful in really guiding us and being able to think about how do we redesign some of these systems and in using the task load index to sort of measure it pre and post some of these redesign steps forward modules, I think is a great place to start. So yeah.
Go ahead.
Well, I think so. Just to sum up, to really encourage, you folks to measure, and whether this starts sort of qualitatively, just listen to stories, ask people like we asked you, what are your biggest drivers of cognitive load? You'll get a ton of information that way. So you could crowdsource and just start there, even in a local clinic. If you want to get more quantitative, again, you can use the task load. You can look in your EHR data. Someone was asking where to access the task load index. It's just an app. So you literally can go to the App Store and type in NASA task load index, download it. You can go online and Google it and print out a paper version of it. But it's open access, so you have access to use it. And then partner. So really partner with your interdisciplinary care team. I think what Dr. Hadid's study demonstrated really nicely is that we want to involve all the members of the care team in understanding how do we make sure our systems support each care team member, and we're not just load shifting to someone else on the care team, but that we're actually streamlining the process and then continuing to iterate in it.
And so these may be the answers to the final question I have for you. But as we wrap up and move into our Q&A, I'd love to kind of end this portion of the webinar on a hopeful and practical note. So if our audience could do just one thing differently tomorrow, one small change that applies these human factors principles to reduce cognitive load or support their teams, what would you suggest?
It's really hard to narrow it down to one because I get so excited about this. But I would encourage us all to notice where we contribute to other people's cognitive load. So, where are we sending multiple separate messages where we could consolidate information and send one thoughtful message later? Where are we just sort of routinely CCing people on things when it makes it so they're not doing today's work today? So just being thoughtful of the way we're contributing to other people's cognitive load will also help us identify where we can streamline and help iterate in our own workflows.
Those are great suggestions. So I think at this point, we'll open up the floor to your questions. You can use the Q&A box, which I think many of you found already, that's located on that black menu bar there. Oh, great, we've got a poll and a quiz. Fantastic. Any questions, please put those in the chat, and let me see if we've got a couple that I can pull up here right now. All right, so and Liz, I'm not sure if you addressed this one already, but someone was asking about methods for maintaining attention or focus without ultimately leading to decision fatigue. Are there methods for maintaining attention or focus without ultimately leading to decision fatigue?
So I think there's a couple key pieces here. So one, I think that this concept of micro breaks here is really important because you do need to know what your own attentional capacity is, and it varies from person to person, and it varies over time, and it varies by day. And thinking about making sure that you're getting those little micro breaks in and being careful about what you're spending your micro breaks doing. So I just went and got coffee before this. You look around in the coffee line, how many people have pulled out their phone and are just scrolling, right? That does not count as a break. So making sure it's meaningful in the way that you're actually spending your break. And then the other thing is there are things you can do to actually train your attention. So when you're not clinical, when you're not doing other things, trying to practice single tasking, trying to practice focusing on one thing and not doing this sort of very dopaminergic urgency cycle thing where we just sort of move from one thing to another, but really trying to practice staying in one task at a time so that when you're in a work environment and trying to do that, that's a skill that you've practiced.
Fantastic. And I see Mike Privatera, who you mentioned previously and gave a shout out to. He was asking about how to reconcile patient safety's desire for redundancy, like in an airplane with a backup set of brakes, versus the multiple sources of mental information that raises cognitive load. So he's asking about what's the best way to explain this to patient safety professionals who might inadvertently be adding to our cognitive load.
Yeah, thanks, Mike. I love that question. I always sort of I actually recently gave this talk to a room full of quality and safety folks, and they didn't kick me out, which was great. But I always sort of reference, the Swiss cheese model, which is put up often when we think about quality. And what we have taken that to mean is that we should put 6 layers of redundancy around every sort of high risk thing. What it really means is the theory of active and latent failures, which says that there's many things that can add up to create an error, such as supervisory issues, workflow optimization, knowledge issues, et cetera, and that we want to make sure that we attend to each of those when we're designing the system. It doesn't actually say to put 6 nodes of redundancy under everyone. And the way that I talk to people about this is if you think about the layers of complexity of our system and you think of each node of things that we need to act on, and then you think about, well, if we put, and that's probably complex enough, right? That's probably more complex than any of our brains can process. I don't think any of us fully understand the systems we're in because they're so complex. But then if you think about putting 6 layers of redundancy under every single node in our system that has to work together, you've made something that's so complex that no one person can manage it, no one person can understand it, and the risk of error actually goes up, and that's really well documented. So I think, speaking to our quality and safety friends in their own language. Now, if you're going to, I always say, if you're going to give me blood or amputate a limb, like, please double check. But do I need 6 copies of a discharge summary? No, I don't. So, I think there's areas where we do want redundancy, but there's areas where we could be a little more fastidious about this.
And I think in my experience, when we all are looking at the science here around cognitive load, it becomes all of a sudden abundantly clear of there's good, effective ways to have those safety mechanisms in place that can meet everyone's needs. And there are ways that we, again, well-meaning, but, less effective ways that actually add to our cognitive load. But when we do sort of share that science, and, we all want the same thing here, right? We want safe, quality patient care, and we want care team members and physicians who, are thriving in their work environment. So there are ways, and this science here is one of the ways that helps us get on the same page in an effective way. I'm going to go back to a question, the micro break question again. And John Ripp has a question in the chat around the variation in different specialties work. So ED versus OR versus clinic might mandate different needs for breaks or micro breaks. Is there any data as to which professions or medical specialties might require or benefit more from micro breaks?
Yeah, it's a really good question. And I actually don't know the answer to data around that. Not that I have seen, but I think what's interesting to think about, there is some data around sort of physical ergonomics for our surgeons and actually needing to take sort of physical breaks and stretching, which is a whole different sort of human factors, right? There's human factors, cognitive ergonomics, but then there's physical ergonomics. I think that our surgeons have done a really nice job in creating, if you will, a sterile cockpit. In many instances, people pass their pagers away or they pass their secure chat away because they are sterile and they have created sort of this sterile environment. And so I think for the rest of us that are not surgeons, thinking about how we can learn from that and create sort of sterile environments around our high risk tasks. So in internal medicine and hospital medicine, that might be during rounds because that's your medical decision-making time, right? That's your high risk task. In emergency medicine, that might be during a procedure. So there's different situations for different providers where you might necessitate a more sterile space, if you will, around your cognitive task and getting clear on what those high risk areas are.
Great suggestions. I see another question in the chat from Brian Goldstein asking, some of our increases in cognitive load are due to overall understaffing, not anything we do particularly, certainly not specific to our organization. Any suggestions on measuring staffing and what would be needed or other ideas? So I know this is a complex question, but I do think that some of the when we aren't staffed appropriately, that certainly can add to some of these interruptions and these increases in extraneous cognitive load. But Liz, interested in your thoughts here.
Yeah, so this is a national issue, right? And we're all facing this. And absolutely, when we're understaffed, and even just on a day, right? If we have a lot of call-ins and people are sick or a lot of FMLA or something like that, it can change the task distribution. of what needs to be done and by whom. I think one thing that COVID taught us is that not all the things we think need to be done need to be done. And a lot of the sort of red tape and bureaucracy we've sort of done to ourselves. And so I think in this space of very lean staffing, we can ask ourselves, do all of these things need to be done? I was in a conversation with one of our IT leaders recently, and we were talking about an alert that comes up at the end of a visit. And that alert the MA could address in a lean staffing environment, the physician could address, but more importantly, that alert actually didn't need to be there anymore because the driver of that alert is no longer pertinent from a policy standpoint or from an accountability standpoint for the organization. So we're really good at adding things. We're not really good at taking away things. And so I think if you're in a situation where you can't control the staffing, which many of us are, but we can control our processes, we can control what we spend our time doing, stepping back and saying, are there 5 things that we don't have to do that we're doing every day that we could take off of everybody's plate, and thinking about it that way?
I'm going to go to 1 or 2 more questions if we can squeeze it in there. Mallory's got a good question on, some organizations will standardize across large groups of physicians that could potentially reduce cognitive load, but also removes autonomy and flexibility.
Yeah.
How do you start to have conversations with organizations about how important it is to reduce cognitive load, but also consider the importance of local needs?
Yeah, thank you for bringing this up. This is a really important question. So the idea here is standardization while allowing for appropriate customization, right? And so a lot of times, because we do want the ability to customize, we don't want to do cookbook medicine, we want the ability to be autonomous and make choices in our medical care, we can kind of resist standardization. And what I would say is we want to standardize everything that's low intrinsic load. So if I'm going to do the same thing every time for a particular patient with a particular diagnosis, I probably want that standardized. Or if my clinic and I as a team are going to do the same thing on every annual Medicare annual wellness visit, then let's standardize that so I don't have to spend the cognitive load every time giving those instructions again, so that when my very sick patient comes in that I need to be more alert for, that I need to be able to do complex medical decision making for, I have that cognitive reserve left. That also means at an administrative level, we standardize what is common across all the areas while leaving room for appropriate customization that allows for that nuanced care. So it really is a very important balance to strike, and one that we need to attend to.
And there are so many great questions in the chat, but I'm gonna go to one last question. So Donald Leiter asks, how do QI methods like Lean Six Sigma fit into this framework? These approaches work towards increasing efficiency and effectiveness. How does this sort of overlap with human factors and cognitive load?
I think they overlap beautifully. I think processes like Lean Six Sigma, or if you're in a high reliability organization or whatever your particular QI methodology is, a great methodology to use to try to reduce cognitive load. And this is where we think about the quadruple aim, right? So when we do process improvement, we do process improvement not only to improve patient safety, and a lot of our lean, when we're wearing a Lean Six Sigma hat or we're doing our quality improvement work, a lot of times that's the lens that we're wearing. And I think the message that I'd like to give us is that it will also help our well-being. And I think that's really intuitive, but we now have data to support it as well. And the quadruple aim suggests the same, that as we make these improvements, it's not only going to improve the patient safety, but their experience, the care team experience, and it will be more efficient care, so it'll be more cost effective. So I think bringing all of these things together so we're delivering care that can deliver on all of those commitments is really important.
I think that's a wonderful place to land, and this is something that is so important for us to continue to emphasize, is that this work to redesign systems to better support the well-being of our physicians and our care team is not a zero-sum game, that as we invest in ways to improve that care team and physician experience, it actually is truly interdependent on with the other aspects of the quadruple aim. And so this work will have positive impacts on our patient experience, our quality and safety, and our financial metrics as an organization as well. So Dr. Harry, thank you so very much for being with us today and sharing your insights. I'm going to turn it back over to Alec to close us out.
Well, just quickly, thank you so much for having me and for highlighting this work. I really appreciate it. Thank you.
Well, awesome. Thank you both so much for your time and expertise today. When we conclude, you will see our feedback survey. Please take the time to answer just the 2 questions there. Your responses will help guide our upcoming programming to deliver webinars you want to see, such as the one you saw today. This recording will be available for you to review on demand with the link you used to join. Our next webinar is How to Integrate Behavioral Health into Value-Based Care, and will go live on Thursday, November 4th. Join our panel of healthcare leaders as they share real-world examples and lessons learned on how to address the challenges of behavioral health integration, as well as actionable considerations for the future of whole-person care in value-based arrangement. If you'd like to attend, you can register now by following the link in the Resources tab to register all in one step. And finally, if you're looking for something with more in-person interaction from AMA Steps Forward, we would like to invite all attendees to join us for our next Saving Time Practice Innovation Bootcamp in Chicago next April. This 2-day in-person bootcamp is specifically designed for clinical and operational change agents looking to eliminate unnecessary work and free up more time to focus on patient care. If you have interest in attending, you can follow the link in the Resources tab. For additional resources and guidance to support your physicians and staff, including those on engineering better well-being for physicians, please visit the American Medical Association website or stepsforward.org. Thank you again so much for joining us, and we hope to see you soon.